Welcome and thank you for standing by. At this time, all participants will be on a listen-only mode for the duration of today's conference. This call is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the call over to Mr. Casey DeCoco. Sir, you may begin.
Thank you, and welcome everyone. So I think everyone should be on now, and welcome to the webinar today. Of course, we're going to be talking about Title IIID and the evidence-based program requirements of that. My name is Casey DeCoco. I am the ACL point of contact on Title IIID, and I work in the Office of Nutrition and Health Promotion Programs at the Administration on Aging here. Today you're going to hear from me and also from some of your colleagues in a state AAA and a AAA and a state unit on aging. So just starting with a couple housekeeping items. We have questions you can submit through the WebEx, through the chat function, and we will be compiling those throughout the presentation, and then at the end of the presentation we'll have a question and answer section where we'll go back throughout, and myself and some of my colleagues at ACL and the state and AAA folks can respond to your questions then. Also, the slides and recording will be available on the Title IIID website following this presentation. Just give us a couple days to get them on there. So the agenda for today. First, I'm going to be talking a bit about the Title IIID requirements, what they are now and what needs to be happening by October 1st, 2016. Then we will be turning it over to our colleagues in the state and AAA. And so you're going to be hearing from the Georgia State Unit on Aging and a AAA in North Carolina called Centralina, and I think you're really going to enjoy those presentations. Then it's going to come back to me and my colleagues at ACL, and I'm going to talk a bit about some of the main lessons that we've heard and then some national resources that are available. And then we're going to turn it over to questions and discussions. And so, again, feel free to please send those in throughout the presentation in the chat box, and we'll be working to compile those. So first, we're going to talk about the Title IIID evidence-based program requirements. So as many of you know, there is an evidence-based program requirement in Title IIID following a 2012 change to our appropriations language, to ACL's appropriations language. And in that appropriation, it said that funds in the Older Americans Act, Title IIID, need to be used on programs which have been demonstrated through rigorous evaluation to be evidence-based and effective. And so when that language was introduced, ACL developed guidance to help states comply, and that guidance has consisted of two different definitions for what an evidence-based program is, and it's kind of, we developed these in order to help move the network in a iterative way towards using only the highest level of evidence-based programs. We're going to talk about those two different definitions a little bit right now. So the current or tiered definition is the one that many of you are probably familiar with. We developed a definition with 3 tiers and told the network that you can be using programs to meet any of these tiers from now until the end of FY16, so September 30th, 2016. And we also know that many states have already moved their networks to using only highest level. So if you're not sure, you should be checking with your state. So these are the actual 3 tiers of the current or tiered definition. I'm not going to go into these, but you probably have seen them before, and they can all be accessed on the Title IIID website. So the future or highest level only definition, it has no tiers, but it is equivalent to the Tier 3 or highest level of the tiered definition. And so we know that a number of the network states are already using this definition, and all states must be using this definition by October 1st, 2016. so the highest level only definition consists of 5 points on 5 criteria, and the main points on them are that the evidence-based program in question needs to have been shown to be effective among older adults. It needs to be shown to be effective with a controlled research design. The research results need to be published in a peer-reviewed journal. It has to have actually been translated in the real world before, so actually implemented in a community setting. And it needs to include dissemination products for implementation. And so the other way that sites can meet the evidence-based requirement that's separate from the ACL definitions is to use Title IIID funds on programs that have been deemed evidence-based by an HHS agency. So ACL is an agency of the Department of Health and Human Services, and the Department of Health and Human Services has 11 agencies, and a number of them have compiled registries of evidence-based programs. And in order to maintain continuity across our department, we allow Title IIID funds to be spent on programs that are considered evidence-based by other agencies within the Department of Health and Human Services. And so later in this presentation, in the resources section, we're going to highlight a couple of those registries that can be useful for you if you're looking for programs. So I just said a lot in words, and I wanted to kind of offer a visual as well. So this is a visual flow chart that is outlining the tiered definition and ways that you can be meeting the evidence-based program requirements now up until the end of FY16. So you can be either using a tiered program or using a program that is considered evidence-based by HHS. And then this is a flow chart for using the highest level only evidence-based programs. So either meeting the future definition or still using a program considered evidence-based by another agency within HHS. So this slide is in response to a question that we get a fair amount about the differentiation between a program and an evidence-based material or resource. So an evidence-based program is different than a standalone material in that it has a implementation evidence base. So I put a little example together here. On the left, if you look, a university created a safe sex booklet based on the best scientific evidence, and then that university is marketing that resource, and a senior center wants to buy these booklets. So that, even though there's scientific evidence, it is not a highest level evidence-based program because there's no dissemination materials or evidence on actually using the booklet. If you look on the right, a university creates a safe sex booklet based on the best evidence and creates a curriculum and the leader manual for using the booklet to teach a class of seniors. So there they've really developed a program. And then in the box below that, the university pilots the program in a few senior centers with an intervention group and a control group. The positive outcomes of the pilot study are published in a peer-reviewed journal. So there they've really developed the evidence base. So hopefully that is clear, but that would be a highest level evidence-based program. And so this slide, in the same vein, is just some common characteristics of evidence-based programs. So programs should have resources for the leader or organization to guide the implementation and dissemination materials. So if you look at the photos here, you see on the left that looks like a class with probably a trained leader there who is following a curriculum. If you look in the middle, there are some pretty clear dissemination materials that the individual is using to work with that older adult. And then on the right, it's probably also a leader or a peer leader, someone who's doing an activity with a group of older adults that is based on a curriculum. Okay. And it looks like we're still getting questions about the slides being available after the presentation, and yes, they will be. We'll put the slides and the audio on the Title IIID webpage. And so the evidence-based definition offers a pretty broad range of what can be considered, but we know some common program types that are out there include class-based physical activity, fall prevention programs, many of you are probably familiar with, and self-management programs, of course. And also, we know a handful of one-on-one health interventions within the home that folks are using that are evidence-based programs folks are using, such as Otago or the PEARLS program. And so this is another visual that is just kind of showing where we are and where we are moving with this evidence-based program requirement. So we know, that many states do not yet require highest level only, but hopefully those states have plans in place to do so and are working on that. And then we know a number of states also already require the highest level only. And, of course, all states must be doing this by a year from now, October 1st, 2016. A little less than a year, really. So at this point, I'm actually going to be turning it over to my colleagues at the state and AAA level. So I think we'll really be able to hear from them some of the good lessons they've learned in really taking this guidance and running with it. So first, we're going to hear from the Georgia Department of Georgia Division of Aging Services, which is in their Department of Human Services, and we're going to hear a presentation from Megan Stadniski, who is the Evidence-Based Aging Services Coordinator, and Gwyneth Johnson, who's the Livable Communities Section Manager. So Gwyneth and Megan, I will be turning it over to you now.
Okay. Oh, you did. Good job. Okay. So this is Megan Stadniski. Thanks so much for having us do this and kind of show you our journey through evidence-based programs just for the past 5 years that we've been working with them statewide, and to share with you our experience of shifting 3D funding all the way to the top tier, as Casey mentioned. So we'll go over our history of bringing evidence-based programs here and our menu of services across the Older Americans Act, and then what we kind of see as our 5 steps to shifting to the highest tier, and then some suggestions for folks who may not have had some of the opportunities that we've had just using 3D dollars. So here's our little timeline. It all started back with the American Recovery and Reinvestment Act, Communities Putting Prevention to Work grant, where we were able to bring chronic disease self-management program, one program, to the state and focus on that. We were really focused on 5 areas, so we were looking at 5 of our regions and doing it very systematically and small, but all 12 of our area agencies on aging really wanted to be involved with this. So through a master trainer training, we were able to get at least 2 people trained in all of our 12 AAAs in Georgia. So we were able to go, you can't see my air quotes, statewide with all 12 of our AAAs in 2011. Then we've been doing a lot of this through grant funding, obviously, these 4 grants that we're talking about. So in 2011, we received a systems integration grant, which one of the components was doing some health and wellness evidence-based programs, and that for us was the Matter of Balance program, and then the Tai Chi for Health program, or the formerly called Arthritis Tai Chi program. And then through the CDSME grant that we received in 2012, both of these are 3-year grants, we were able to expand even further our implementation of the chronic disease self-management program, introduce the diabetes self-management program, as well as Tomando Control du Sous Salud. And then we have a large Korean-speaking population in Georgia, and so we were able to actually translate the 2012 lay leader manual, the CDSMP lay leader manual, into Korean. So that is available if any of you out there have Korean-speaking residents. You can contact Stanford to do that. We did have for our requirements for CDSMP, which started in 2010, that any of our master trainers had to implement their first 2 workshops as Stanford requires, but then every year after, they are required to implement a lay leader training. So every 365 days, these pairs should be doing lay leader trainings. And we require that for the Diabetes Self-Management Program, Tomondo, all of the evidence-based programs that we have asked. And then our lay leaders or our coaches, if they're matter of balance, are also required to implement one workshop every 6 months, so at least 2 a year, which may be a little bit more than required by the originators of the program. But we do this to make sure that our leaders and trained individuals maintain familiarity with the program, and then also we are getting the program into the hands of our fellow Georgians. Finally, we were awarded the Falls Grant, and so we were able to expand Matter of Balance and then introduce Otago, which helped us to meet new partners or make new partnerships with Physical Therapists Association here in Georgia. And the Tai Chi for Health program has been so popular that it is going on its own, and we are committed at the state level to make sure that we coordinate a training at least once a year so more individuals can become trained as instructors, and we can expand that program as far as it will go. And for that, individuals are paying for registration for the training and covering those costs 100%. So that's helping us to sustain that program. So here is our menu of evidence-based programs, which include 3E, 3D, and then some other programs through our hospital transitions initiatives across the state, where area agencies on aging, either through help from the Division of Aging Services or on their own independently, became trained in the Coleman model or the Care Transitions Intervention, and then the Bridge model to do hospital transitions. And then, as I mentioned, here are a listing of Title IIIB programs.
And this is Gwyneth. We have also started working with our university partners across the state to make sure that we're moving in an evidence-based direction for our nutrition programs as well, so exploring evidence-based nutrition education.
Okay. And in anticipation of these changes, we have systematically shifted the use of these funds towards evidence-based programs. And so we early on tried to seek out these grants to help us bring these programs or get the foundation laid for these programs as early as possible, so that we, if we were able to receive a grant, we offered coach trainings or master trainer trainings to everyone and made them available to anyone across our state and anyone in our partner agencies, public health, sister state-level agencies, so that we could spread them not just through our aging network, but through other networks as well. Okay, which brings us to the 5 steps that we kind of took that enabled us to shift to this highest tier, and that's choosing the right evidence-based programs, building the infrastructure for those programs, writing policy to support that, doing some business planning, which has been a really interesting venture for us, and then working through our resistance to change. We know that this was not an easy thing for our partner agencies to do, but we wanted to make sure that we set the stage for them at the state level to support them as they shifted to these programs. So how do you choose the right evidence-based programs? For us, we wanted to be able to expand rapidly, so we did look at the lay-led, train-the-trainer programs, so that we could do this pyramid scheme and build out as quickly as possible, but also that they were peer leaders, so we were not having to pay a lot of money for credentialed individuals or individuals with certification that we would not be able to afford or sustain that infrastructure. And then honestly, we looked at what grantors were funding. If there were programs that fellow state agencies had already received funding for, like the Chronic Disease Self-Management Program, those were the ones that we were looking to write into grants. What? I don't know what. There you go. Okay, that was weird. Yikes. Sorry. Okay,
Megan, it looks like there's a little trouble here with the slides. Let me try and make you the presenter again here.
Okay.
If not, I can just forward them for you. But
okay. So for choosing the right programs, and then also we looked for what was being funded, and we shifted in that direction. We also worked with public health, our state public health partners, and they helped us understand, hey, we have a lot of individuals, older individuals with diabetes. Let's look at the diabetes self-management program. We have a lot of people falling in this region of your state. Why don't we focus Otago in recruiting physical therapists in this area of the state so that we can do the best good with these programs and probably reach more individuals who'd be interested in it because they're suffering from the conditions that we're trying to help them with. So we did that, and all of this was done in partnership with our area agencies on aging, and they brought in their partners as well. And so after choosing that and being awarded the grants, we jumped right into building the infrastructure for these programs. And we did them systematically, and it wasn't all 7 programs at once. We started with one and figured out how our network would handle it, and we built it from there. And to make implementation as easy as possible for our statewide partners and to maximize the money that we were investing into these programs, the Division of Aging Services was able to hold the license. Any licensure that was needed, we were able to purchase that from the state level and cover all of our partners, so that each partner was not having to do that on their own. We also purchased supplies in bulk from the state level so that they only had to ship it to one location. And then during meetings, or as our state employees were going out to visit our partners in the field, they would actually transport the material. I don't know if I would fully recommend that. But
it does take up a lot of space in your office, so
yeah.
that can be a concern.
Yeah. But it was a good excuse to get out into the field and make sure that we were seeing face-to-face with individuals. Which brings us to meetings and buy-in. We hold at least annually a face-to-face meeting and brainstorming session where we invite all of our area agency on aging wellness coordinators, all of their partners that they can invite, community-based agencies, county-based agencies, public health partnerships, hospitals, anybody that we can invite to these meetings. We bring them together so that we can have a participant-driven meeting where we talk about barriers and we brainstorm and we problem solve and make sure that we at the state understand what is happening in the field and how we can make it easier for them. And we do this for all levels so that we know what we can do at the state level to support our partners in the field, what they can be doing to work on issues to better support their county-based agencies, and so forth. And as I mentioned, when funding permitted, we held trainings for at least 2 representatives from each of our partner organizations so that they would have a partner and be able to sustain programs like the Chronic Disease Self-Management Program at the local level. And then partnerships. I know that the Centralina folks are going to be talking about partnerships and how important they are, and making sure that we're looking outside of our traditional aging services partners, and we're looking at for-profit organizations and corporations and agencies who want to help support community efforts and public health efforts.
And as we're looking at those partnerships, non-traditional and traditional, we spend some time looking at what those organizations need. What are their outcomes and goals for their programs, and how can we make the programs that our network provides more attractive to them? We recently attended the Physicians College Conference, or College of Physicians Conference here in Georgia, and provided a one-page flyer that talked about evidence-based programs, provided the single ADRC number, talked about the opportunity for referrals and community supports for their patients, and are really working to start that referral system for our state. We also looked at hospital transitions and working with our AAA partners and other partners, kind of bundling these evidence-based programs into those hospital transition packages. Working with our QIO with health departments, making sure that that our 1-800 number is in everybody's hands, but also with a list of the opportunities for referral that there are. As we work towards managed care organizations, and we have not yet been completely touched by managed care, but we're preparing for that. We're looking at what the outcomes are for each of the managed care organizations that could potentially come into Georgia, and preparing how can we prepare the network to meet the needs of that managed care organization, as well as the bundled payment systems. To get our network ready, we really had to take a hard look at our policy. So we wrote the policy in 2012 to reflect the changes to Title IIID. We recommended that shift towards the top tier, and at the same time, we're bringing trainings into the state to support the movement to that top tier. We have a commitment, particularly in my section, that every quarter we will look at our policies, and we will look at them based on our conversations with the AAAs, what we've observed through our programs, where the barriers are to success as we're trying to implement these programs and expand our reach. We've looked at our fee-for-service policy and worked to strengthen that to provide better guidance, but also to open up the possibilities while still holding our partners to the letter of the law. We've looked at the wellness requirements for senior centers. Our site councils now have to have a wellness goal for each senior center. And so within that, we're able to focus on some of these same topics that we have evidence-based programs to support, which has been a good way to help implement that and bring awareness not only to the staff of the Aging Network, but to the senior participants as well. We're also looking at policies to support our AAAs working in partnership with one another across AAA boundaries. If one AAA is able to provide an evidence-based program on a larger basis than another one, then maybe they can work together. And so really working with the policy to support those kinds of needs. Along with those changes, we, with the Systems Integration Grant, spent some time working on business planning. And we took this very seriously. We brought in a consultant and worked with them to develop a year-long training which resulted in a business plan as an end product. Each AAA that participated in that, and 10 of our 12 participated in this training, each AAA decided which programs they offered already or which programs they were being trained to offer they were going to write their business plan around. So it was very focused. They worked through what are the concerns for business planning, working with a consultant for many of them, and each AAA then produced that business plan. One of our AAAs, the Coastal Region AAA, actually approached a hospital who had not been fined for readmissions and talked with them about the benefits of a hospital transition program to prevent that type of fining.
To continue what was done at the Systems Integration Grant and Business Planning, through our Falls Prevention Grant, we are actually working with 4 area agencies on aging, and this is our shameless plug. They will be available as consulting agencies to assist other AAAs across the country to establish solid, sustainable practices with evidence-based programs. They are actually continuing with the contractor that we initially worked with our Systems Integration Grant. They are going to have a full package together of what they have done to successfully embed evidence-based programs within their regions and how they are making them sustainable. So you all will have more information on that. Please reach out to us if you are interested. And then also we really look and continue the discussion with our partner agencies about the possibilities for sustaining the program, whether it be fee-for-service or sliding scales, reaching out to community organizations to promote sponsorships, looking at becoming accredited for the Diabetes Self-Management program, also looking at Otago and engaging new partners like the Physical Therapy Association of Georgia to get PTs involved in helping us keep people from falling. And then from some of our meetings, we know that we are in need of statewide marketing and ensuring that that starts at our level at the state so that we can have our brand out there and that the same message is happening in one part of our state and happening in another part of our state. And we can have this uniformed statewide message. Has this been easy? It is. No, of course not. It's an evolving process, and it's a lot of change. And so some of the, if you look at our little cons list over here, these are some of the things that we hear regularly about shifting this small little amount of money to evidence-based programs. And so I think in the past, much of this money had gone to support ongoing programs at our senior centers. And that doesn't really happen when you're using when this money goes to support short-term interventions, evidence-based programs. There's not a lot of money in 3D. I think it comes out to be just about $1,000 per county for the entire year, and $1,000 doesn't support a ton of different workshops. And going from being a little bit more flexible to something more rigid and defined is difficult. So we appreciate that, and we wholeheartedly understand that it's difficult, which is why we have done all that we can to get out of their way from our level or make it as easy as possible to have these programs available. So what can you do? What do you do to use this funding source in a more prescriptive way? We purchase programs or we invest in programs that we know are effective and can actually use this foundation of amazing individuals to sell these programs to new and non-traditional residents in our state so that we are touching more individuals than we possibly could just looking at our senior centers or in a narrowly defined population. You can pool this money. We have AAAs who are brilliant partners with one another, and they will pool their money to have a training or host a training in a centralized location and invite people from multiple regions or even across the state to this training so that it reduces the overall cost for one AAA. You can serve more individuals through these short-term programs and introduce them to a self-management technique so that they can carry that on through their lives. And we know that our older adults oftentimes are kind of the matriarchs or patriarchs of their family, and what they learn, it trickles down to the rest of the community. So you are affecting a greater change than just having an ongoing class at one location. And wherever you go across the state now, your fellow neighbors, your neighbors have the same access to similar services that are proven to improve health outcomes. And again, we have a unified statewide menu that all of our Georgians can access. So I know that we were heavily grant funded, and that was a huge way that we were able to get this process started. However, 3D is a good bit of money, and if you take that money and are able to get your partners together, I know they're not minions, but they're cute, and minions are cute. Anyway, so if you get your partners together and come up with one program that you think that your partners are interested in getting together with, and have them pool their money and use federal, state, and local money as seed money to get these programs, these evidence-based programs, up and running in your communities. To start with, though, you all have to have that same goal and make sure that you are unified in what you all are trying to accomplish. Use that money to get you started and keep going with your partners. And charge for programs to funnel money back in to support programs to help individuals who truly are not able to pay for the whole cost of a workshop. However, with that, and I'll leave you with this, I would just caution not to assume that an individual cannot afford something. Don't put that in their mouth. You can always ask and go from there. So always be thinking about that sustainability piece.
Okay, thank you very much, Megan and Gwyneth. That was really great, and it was really beneficial to hear from you guys. So thanks for sharing your experience at the state level. So next we're going to hear from our colleagues at the AAA level. So we're going to be hearing from Centralina, which is in North Carolina. Speaking to everyone today is going to be Linda Miller, who is the Aging Program Director in the Centralina AAA, and Annette Demeny, who is the EPHP Coordinator for the Centralina AAA. And Linda, I'm going to hand over the presentation to you.
Thanks, Casey. Actually, I'm going to start it off. This is Annette Demeny, and like Casey said, I'm the coordinator for the HPDP programs. And I'm going to get started and talk to you mainly about our region first, and then I'll turn it over to Linda and let her talk more on the funding side and the coordination. So Centralina is the second largest area agency on aging in North Carolina. There's a total of 16, and we serve 9 counties surrounding the Charlotte region, and Charlotte's in the Mecklenburg County, as you can see that. We also serve a wide demographic range, both rural and urban areas, so we have a lot of reach to both, all the way from Iredell down to Anson County, which is a very rural area, so we have a widespread range there. We also are housed in an RPO, which is a regional planning organization, which provides transportation, planning, mapping, and GIS support. So that's a great benefit to us, especially with data support and things like that for our programs. We also serve as a regional evidence-based program for, or a hub, a site or a hub for trainings. And that's really for the central and western part of the state. And then the eastern part of the state, I think, has some of their master trainings there, but we are in mainly the central and the western part. And we deliver most of the evidence-based health programs in North Carolina. All right, this slide here really focuses on the 5 core evidence-based programs that we have in-house that we focus on mainly. And you can see the big core of them is the Stanford model, which is the Chronic Disease Self-Management Program, the Diabetes Self-Management Program, the Tomando, which is the Spanish version of the CDSMP, and then the Manejo, which is the diabetes, the Spanish of the DSMP. And then we also have a Matter of Balance program, and that's offered in the English and the Spanish versions. And I didn't include this, but we also support powerful tools for caregivers, and I did not include that, but we do offer that, and we have master trainers here at Centralina, and we offer that in our region as well. Here's some numbers for FY15. We had a total of 105 workshops, and I did not include, I think we had a couple powerful tools for caregivers. I think we had 2 or 3 workshops that I did not include, but either way, it's 105 workshops, and you can see 47 of those were Matter of Balance, the Matter of Balance program, and then 58 of those was the CDSME, which is really encompasses all of those, the Stanford models there. Okay, here's a real quick overview of just the Matter of Balance. As you can see, we had a total of 680 total participants in this FY15 year. We have 4 trained master trainers in our region and 67 trained leaders. This past year, we've conducted 2 Matter of Balance coach trainings, and then we also did a master training here at Centralina, which we have done now for 3 years. We are the hub for the southeastern states for master training, so we have that in June every year. So Maine Health, who oversees the Matter of Balance programs, typically have master trainings in Arizona and Maine, and now North Carolina here at Centralina. We're the hub for the southeastern states, so we're real proud of that. And here's an overview of the CDSME, which, like I said, encompasses all of these programs. We have 621 total participants. We have 7 master trainers, 123 lay leaders. We conducted 5 lay leader certified trainings this past year. And then we also teamed up with Georgia Division of Aging Services and offered a master training for the Tomando program, and had 3 states represented and also Puerto Rico. So that was a fun training there. All right, and this is a quick snapshot of just who we serve. As you can see, our top 3 diagnoses that's reported in our programs are hypertension, diabetes, and arthritis, which was not a surprise to us. 6.5 of the attendees had multiple diagnoses, and you see the attendees female is 79%, 21% male, so we're really trying to work more on that. I've seen a little bit of a change in that and seen more males come to especially the Matter Balance programs and the diabetes programs. So hopefully we'll have a shift in that and get more males into the program. And then you see our completion rate is at 73%. All right, I'm going to go ahead and turn this over to Linda Miller.
Good afternoon, everybody. I'm glad you're all here. Just going to move into even over the years why we think we'd be successful, and we've been successful. Annette threw a lot of numbers, and to some of you they might seem small, and to some they might seem big, but it took a lot of years of building this program up and a lot of patience to get there, and I hope that during our presentation you really see some common themes between a little bit from what Casey said and more so from what Megan and Gwyneth said, and because common themes are good. We're hoping that those are things that are going to stick in your mind and say, well, those are really good things, and hopefully those are some things we need to be successful, or I see those through both programs. So for the Older Americans Act, the 3D fund support, what we did years ago, and we're very fortunate, much more fortunate than the people in Georgia after Megan gave me that of about $1,000 a county. We're much more fortunate than that in our region, in that we get a nice chunk of money in that early on. Of course, we gave all the money out to what we call our community services providers. We don't do a lot of direct services in-house in the North Carolina AAA format. A lot of it is subcontracted out to the individual counties maybe, and they do that. But when the 3D money started to change about 4 or 5 years ago, we began keeping a combination of some of the funds in-house to be able to absorb those foundation costs that were going to be required, such as purchasing a license or training leaders and paying for a coordinator salary, as opposed to giving it all out, because we knew that if you didn't have that foundation, you weren't going to be able to increase capacity. And then what we did is we give some of the funds awarded out to our subcontractors in the region to assist them with expansion and sustainability. We also early on designated what we believed, yes, probably because of some grants that we got, that we were going to call these our core evidence-based health programs. Yes, people, there's a long, long list, like Casey was saying, but we wanted to say that, given our choice, we were going to offer these core programs with this 3D money, and those were the ones that we wanted to grow and develop. Didn't mean that they can't do other things. It's just that the bulk of the money was going to be used to develop these core workshops. So we monitor the workshops in the 9 counties for program fidelity and for allowable expenses, and what we did is a few years ago we put out a proposal process to the people in the region who think that they have the capacity to deliver a evidence-based program from our core list first. And they submit, maybe it's a senior center, and they say, well, we think that we're going to do 3 Matter Balances this year. We think we can do 2 chronic disease self-management and maybe 1 diabetes, and that's their proposal. And we maybe get, I don't know, Annette, what, 15 or more proposals? Yeah, probably about that. But everybody writes it according to what they think their capacity is, and we do the training of the leaders under our license and maintain them and maintain the fidelity and keep an eye on them. But then they tell us when they're teaching classes. We get the materials and supplies out to them. We get everything they need. We get the marketing material out because it's all consistent. We maybe put their information on it to RSVP for the class, but it's delivered a very consistent message. And then upon receiving all of the required paperwork, the pre- and post-test, the sign-in, everything that we need, then we reimburse them $600 or $600 per class, and we released them a check for $600. But again, it had to have been a successful proposal that they wrote, that we approved, and we don't always approve everything that they wrote, and that's how we began to also disseminate, I think, wider and get some buy-in from some of the congregate dining sites, the senior centers, some faith-based communities, some other nonprofits, some of the departments of social services do them, and that's how we felt we were able to spread that. And as we said, we started out really slow. You know, we had some of the first people trained way back in 2007 with a grant, and maybe did 2 or 3 classes that year, and then added something each year. And then in 12 began to do the Tamondo, and then we just started the diabetes Spanish program. It takes a long time. So more about that, again, building that infrastructure or that hub like Gwyneth and Megan said, or we like to believe that we're an evidence-based health program regional center. We maintain the licensing. We maintain and select all the master trainers. They don't have to be central line of staff. We have the only reason that I think we were able to have so many master trainers is we've got some phenomenal partnerships, particularly because we've got no one here bilingual, but all of the Spanish programs have been maintained because we have some wonderful partners. And then again, like Megan and Gwyneth said, the bulk purchase of materials and supplies really does save money. It's not pretty in our office, but it saves a lot of money. We also, for the matter of balance, for instance, the participants get a handbook. Well, we started printing that on our own with all of our just as it is, and we were able to get that down to like barely $5 a book when we ordered a few thousand of them. So that's a way that we've been able to even do some of that and really save some money. As I mentioned before, we have a focused outreach and marketing with a very consistent message. We don't recreate the wheel. We don't want to. NCOA has been a wonderful resource with a lot of their marketing materials, if we could use it. CDC, ACL, everybody's done that. We may tweak things a little, but we use a lot that's out there, but we want everybody using the same posters, brochures. We want everybody delivering the same message, and we want to make sure that we're giving credit since we supply all the materials, all the marketing, and so forth. But we really felt that we were able to stretch our funds a lot more. We're also talking to, as the years, this year we're talking to some of the other AAAs about ways we can better partner too, because they're also seeing that lack of capacity and sort of hitting a wall with growth and with the ability to make their money stretch. So, and again, we're also able to conduct fidelity from here, do visits on all of our workshops and leaders, and also make sure that I think we wrote in about 2010 or 11, we wrote our own centralized policies and procedures. People were struggling. A lot of the senior centers would get the money, but they didn't know, so we don't let anybody buy food for the last couple of years, so you say that, but you still have to write it into policies and procedures, or we'd put maximums on certain other things, or what they could spend the money on, or we had to reiterate that people had to train, minimum once every 12 months, but the policies and procedures were also a big help. I think that was mentioned a couple times that it's really important to designate a full-time coordinator to conduct all those logistics, the full-time tasks, of administrative tasks, but keeping everybody in line as well. Those of you that work with a lot of volunteers, even if they're professional volunteers, know that it takes a lot of time and a lot of customer service and patience. We have the centralized database for all the workshops taught in the 9 county areas, participants, leaders. If we have a leader, we know it's all so that we know what leaders are due to teach, if they're lapsing, if they need to teach, and all sorts of other data collection. We do other training. Fidelity just isn't an annual visit to a class. We feel Fidelity is such things as an annual training retreat. We get all the leaders together once a year. It's a newsletter giving them hints about what they need to do or what's happening or what we've noticed. It's surveys to make sure their needs are getting met, or surveying the host agency sites to see if, was it easy to set up a matter of balance class? Did everything go well? But those are things that we feel we try to do Fidelity all year round. We can get in centralized referral, especially through the state. Our state has a quit hotline, but they're also trained to ask for, do you need help to get to a chronic disease self-management class? So those types of things will come here. As Annette said, we try to have all of the leader and master training done here. And we also feel that centralized coordination is a marketable product. We have had health departments that say, well, we want to get trained in the chronic disease. And we say, well, that's great. If you can get trained here at Centralina, and we want to have our own license and do our own thing. That's great. But why build something when you can buy it? So we have also made a little bit of money off of offering our coordination and some of our benefits to other people who want to get a program started up. So that's helped a little bit too. Don't buy, don't build it yourself, buy it. Partners and collaboration has been wonderful. Probably don't have to tell anybody that. But we really make sure that everybody has some skin in the game. There's something you can bring. Even if you're a small nonprofit and you want to get on board, but I can give you a leader and I'll pay that leader and pay their gas when they go to train for you, even though you hold the license. So everybody contributes something. We use an agency and a leader, memorandum of agreement. We have an evidence-based health program committee or coalition. I think we call it an advisory board, actually, so I don't have either one of those right. Provide a lot of partnership feedback and data when they need it. We also use a lot of people as champions to help us promote and market out in the region. Those types of things are really important. We want to make sure everyone gets credit. We're not in this to, all by ourselves or to, we may take the lead, but we really want to make sure everyone gets credit. We really also network with everyone and do not reinvent the wheel, not at all. And we also, I wish I, had money for every time somebody calls and says, well, how much does a program really cost, and what's it really going to be to run? We have all that stuff ready so that we don't have to throw it together. We really want to do a really good analysis for people to say, well, this is what this costs, and this is how much time we put in on a class. And that's how you do a really good cost analysis, so you know what it costs per person or per leader when you're training them truly to cover your costs, and make sure you cover your staff time as well when somebody asks how much these programs cost or what it'll cost them. And that kind of leads into then don't undervalue yourself. Make sure that you get your costs covered. Effective leadership has also been something that I think has helped us greatly. We think that Georgia, we were writing notes and taking notes when you guys were talking. We've been doing this for years, but they said some cool things that we hadn't thought of, and we're going to call them right out. But your state unit on aging, in my mind, has been one of our biggest advocates and has been huge here in North Carolina. We call them constantly. I'm sure they're sick of talking to us, but use your state unit. If you're a AAA, I see a lot of AAAs up there on the attendee board. Use your AAA. I mean, your unit on aging. They're great. Again, Annette is sort of seen as the expert in our 9 counties. When you designate a coordinator, she's that go-to person. They have to have that persistence to get classes booked and get, and be patient with volunteers, that passion about these programs, be really flexible to hit the ground running and creative to get these things working and running, and that vision to be able to, get all this stuff into practice. But once we really, in those early years, we weren't able to set that up, but once we set up a position like that, we really saw things grow at a rapid pace. Of course, your champions should be leaders for you. That advisory council is helping us a lot. We also are trying to go for the diabetes self-management and become a Medicare agency and then get the DSMP certified through the AADE, the American Association of Diabetes Educators, so that we can get the workshop reimbursed through Medicare. And it is a long road, but we're being patient. And that advisory council is also something that you have to do for that AADE application, so that's coming in really, really handy. Our master trainers and T trainers are just invaluable. And again, if you can't lead, if your leaders, if it's not for them, with help to people to identify, well, then what can you do? Continuing with that, we from day one have done pre and post measures. Of course, Matter of Balance has sort of come with that built into it, and we've really appreciated that, but we've continued to do that with all of our CDSME programs. Right now, we're involved in the CMS, Centers for Medicare and Medicaid Services, WESTAT study, in which we're pre and post. They're measuring 6 months later to see if these classes are effective, if they're reducing some sort of, they're looking more at a cost analysis. And that's been a real interesting year. It'll be a year. We're closing next month or a month after. Early on, we also purchased a license for something called BuyIn called a patient activation measure. It's just a quick 13-question survey that looked at somebody. We would give it before the class started and then would follow up 6 months to see where you are and how you're motivated in your healthcare regime for change. So an example might be, I understand my medication regime and I am ready and able to change it. I'm in stage, 4. I'm far along. Or I don't understand it. I'm really not self-motivated. I don't know where to go from there. So we were seeing if there were numbers, and that would be moved after they took the class. So we're really actually having the university help us analyze that now, and we're helping to have some really good numbers with that. So leadership is just that, measuring anything, because data is going to measure the effectiveness of your program. But again, as a selling point to new partners and sponsors when they see that cost savings or who you're saving. It's not just about demographics. They want to see those cost savings. We also suggest, and I think that Georgia said this, in that you take that time to write a business plan. Our state helped us write one, at least a template, and then everybody took it and started to put their own local data in. So that was a huge help. But it gives you that blueprint to move forward. We're really moving also the needle on charging organizations for our services, more private pay workshops, charging more for leader training, and particularly for people out of our region, and looking more at foundations and grants as ways to enhance our 3D money and increase that sustainability. We're looking more at some global or systemic partners, our vets, some insurance companies, some of the hospitals. We talked about the DSMP as a Medicare reimbursable service. We worked with Georgia, and we're working with the Maine Health with the MOB to become not only a site, but to see if one of your staff would be interested in T training or lead training, to bring that income in and have those types of things to train master trainers. And of course, we do a lot of research and call others on our call other people to see what they're doing. There's the new Evidence-Based Leadership Council, NCOA, ACL. They've all been huge resources for us. And just be patient. There's our contact information. And Annette, anything I missed? I know Casey has questions.
I don't think so. I think you did a great job, no?
Yeah, thank you guys. Thanks, Linda and Annette. That was really excellent. And we've got a lot of great questions coming in. I have a few more slides to go through, and then I will go back and go through these questions, and hopefully we'll have time to get to them all. And if not, we can kind of follow up individually with folks. But thank you guys again. So I'm just really quickly going to go through kind of some of the themes from both of those presentations and kind of core lessons that we are hoping folks are getting. So, I think we heard from both presentations how important leadership from the top can be and really having that buy-in from committed leaders. And I think, one of the ways to get that buy-in is really highlighting how evidence-based programs align with the mission and using available data to make that case and to link the mission. Okay, I think sorry there, a little slide administration. As Linda just said, state leadership is really important. It's great if the state has a health promotion person identified, whether or not that's their full-time position or it's part of other responsibilities, but it's nice for the network to have someone to contact, and hopefully that state person can provide TA to the AAAs, or if not, they can link AAAs to one another, which is a really important resource. And in that vein, we definitely recommend holding conference calls on evidence-based programs within the states. Centralized websites, that's great if the state has the infrastructure to do that, but that also, may not be doable for many folks. So the hub model is one of the key themes we're hoping comes across in these presentations. As we've seen with both of the presentations, these folks did a really great job utilizing a hub model and kind of leveraging a small amount of resources to be able to build a pretty systematic approach. Also, a theme was obviously leveraging infrastructure of prior or current grants. Obviously the reach of these grants varies depending on the funding stream, but there's the grants that you as an organization may have received, but also the grants that your neighbors or other AAAs in the state may have received, and be aware of that, and there may be a way to take advantage of that. And in that same vein, one of the key concepts is don't build from scratch, as Linda said very well. See who you can buy services from and partner with other organizations to braid funding. It's really all about leveraging those existing resources. Now we're going to talk briefly about some of the resources that are available nationally, and then we're going to go to questions. I see some good questions still coming in. So two resources that are really kind of comprehensive, soup to nuts, evidence-based programs in a community setting resources. So the first is this website from some folks in Texas, who put together this really nice site that really offers comprehensive guides to evidence-based programs in community settings. And then the second link on there is from the National Council on Aging, NCOA, who has put together some really great guides for also for understanding, implementing, and also business case resources. So these are resources if you're really looking to build from scratch or you're just kind of troubleshooting a particular problem, but they're pretty comprehensive. Linda mentioned the Evidence-Based Leadership Council, or the EBLC for short. They've just redone their website, and they have a number of notable programs that they've been doing in the network for a long time, and can be very valuable for folks. And this 101 fact sheet is just a one-pager on evidence-based programs that can be useful for folks who you're trying to introduce the concept to. So this link in the middle of the page here links to a PDF that contains a list of evidence-based programs that ACL and NCOA put together in 2012 and 2013 to aid the network in finding and implementing evidence-based programs. So everything on this list meets the highest level criteria, but we stress that programs do not have to be on this list in order to meet the highest level criteria. The list also is not particularly updated now with broad updates. There's more just minor updates to program costs and links and that sort of thing. So that's important for states to keep in mind if they're utilizing this as a resource. These are these federal registries. So in the beginning of the presentation, I spoke about how if you're using a program that has been deemed evidence-based by another agency within Health and Human Services, then you can use Title IIID funds. And so these are three great registries of such programs. The first is from the SAMHSA, and it's a pretty robust registry. It's got about 350 programs in there, and they're filterable and searchable. They're probably not all relevant to older adults, but there's certainly ways to look at the filters, I think, and see which ones are. The Compendium of Falls Interventions, many of you may be familiar with that, but that is a great resource, and obviously very germane to our network. And that last link on there comes from the National Institutes on Health, and it's a cancer control and prevention intervention registry, but it's got a lot of great physical activity, nutrition, smoking cessation interventions on there, and it's filterable by older adults. So if you're looking to learn about some new programs, that could be a great place to start. ACL also has our own registry of evidence-based programs on our website. It's called ADEP, and there's 11 programs on there, and we put this together as a way to share with the network and other interested parties some evidence-based programs that are relevant to our stakeholders. And so we have not had capacity to review a great deal of programs, but there are some very comprehensive reviews on there. So if you're looking to learn about some programs, it's a good place to go. And again, we want to stress that a program does not have to be on this list in order to meet the highest level evidence-based requirements. This is just one place to find them. And some past presentations from ACL and our partners at NCOA. These are other webinars that are available here, and they're available on the Title IIID website. And this presentation will be put on there as well. Okay, now we are going to get into the Q&A section. And so I am just going to be going through and looking at some of the questions and sending the questions out to the group, both the group of presenters and the folks I have here with me. So let's start with one that I saw that was pretty directed to ACL, and that was here we go. Oh, from Joanna. If the 5 points of the future definition of an evidence-based program is met, does the program have to be approved by ACL in order to use in the highest level only? And so that's a great question, and one that we have gotten before. So the answer is no. The Older Americans Act puts the responsibility and ability to come up with the guidance to states, and so we know states are using multiple different ways of looking at the programs that they are going to consider eligible for the highest level, and that's something that I've definitely seen as a need since I've been here, and so we are looking to develop some resources to help states who don't already have a system in place for assessing whether something is a program or not, and they don't feel that they have that capacity. We're looking at kind of guides or ways to ease that process for states. And so stay tuned on that, certainly. And this is a question that I'm going to put out to the group, that has anyone, from Mindy, has anyone approached MCOs and contracted with them to help move toward building a private business line?
Okay, I don't know if anyone else will answer that, but I'll take a stab. This is Laura Lawrence, and I'm the director of the Office of Nutrition and Health Promotion Programs. And so Title 3D falls in my office, and I've just been tickled pink that I was able to hire Casey to handle this portfolio. Excellent question. As you all probably know, ACL has taken very much interest in how we can connect with healthcare entities and show them the importance of our programs in helping the individuals that they serve on the healthcare, more of the clinical side, and how we can partner together and how they can pay for our programs. And so, yes, we do have some examples of networks throughout the U.S. that are made up of some of our AAAs, direct service providers, et cetera, that do have contracts with healthcare entities. And specifically, I don't know if you're familiar with it, but we're now in our second cohort of a learning collaborative to learn business skills for doing exactly that. And so I think between the two groups, we have maybe 20, 21 networks across the U.S., and they have entered into, so I'm guessing numbers, something along the 15 to 17 contracts so far, and we are working on how we can share all that they've learned in terms of doing this with everyone in the network. So again, that's an ongoing project, and you'll be hearing more about it. So I hope that touches on some of that question.
Thank you, Laura. And I have a question for Georgia, and it may be repeating a bit of your presentation, but the question is from Jennifer, and they asked, Georgia, does the state require AAAs to implement the menu of programs you shared, or are these options that AAAs can choose from and or offer other evidence-based programs?
Our AAAs can choose whichever one is right for them. These were just the programs that we were able to bring through grant funding, and we're able to help folks get up and started. There's one AAA who was not finding success offering the chronic disease self-management program at all, but as soon as they offered the diabetes self-management program, their program kind of flew and went. It was the right size program for them. It's the DSMP. So I hope that answers the question.
I found it interesting that that particular area is one of the diabetes hotspots for Georgia, which we were able to look at and do some targeting with our public health departments.
So we would allow our AAAs. We encourage our AAAs to do whatever is going to help their area and their region. These were just programs that we were able to bring through grants.
Most of our state is covered by most of the programs, however.
Yes.
Okay, great. Also, this is a question. Who was the funder of the Systems Innovation Grant?
That was an ACL grant.
Thank you. And so that's the ones that were directed to you. Georgia and North Carolina, this was a question for both of you. Do you have any tips for supporting Spanish language programs, especially if you don't have a coordinator who is bilingual?
Partner.
Yeah, community partnerships are key to us for any language venture that we go into.
And I think that Linda mentioned having your champions and finding your champions. We are very new to Mondo Control. Actually, our partnership with Centralina and getting master trainers together is our first venture into truly Spanish culturally competent programs, Spanish-speaking culturally competent programs. And the 10 folks that we had trained, they have teamed up. They are all teams, and they are huge champions within their communities to bring this program there.
And this is Linda and Annette in Charlotte. They're right. All of our Tamundo and the Manejo, the diabetes for Spanish master trainers, none of them work here. What we've had to do, we do have staff in the regional planning organization, our Council of Government, that are bilingual that help us if needed with interpretation. But a couple of the Tamondo Master Trainers, one is a Senior Center Director of a multicultural international senior center, and she's bilingual. She has been a blessing because we defer most of the issues, or she'll do some of our interpreting of hard copy materials if we need it, or to change things on the website or different things. She's done all that for us, and she'll call a leader if we have a problem or an issue. But she has just been our best champion. But again, they're right. We couldn't do it without them. The partnership has been amazing.
Right, and with the diabetes, with the Manejo, we're like we were saying on the slides. We're very new with that. We just trained two master trainers who are nurses in our Caroline's healthcare system here in North Carolina. So that's going to give us a really great way of getting into the healthcare system, not only getting referrals, but also, getting leaders trained as well for that program. So partnership is key, especially in those bilingual situations in those programs. As a matter of fact, today we have a Tamondo program going on at a senior center there's no bilingual people there, and so that work there. And so one of our master trainers is really, taking them under her wing to try to get this program going in that senior center.
Great, thank you. And one of the earlier questions we got was, is there going to be a central place for all highest level evidence-based programs? And that's the point of the guidance is to kind of provide the criteria that can help folks find and recognize evidence-based programs, but there's not going to be a central ACL place where we say these are all the evidence-based programs out there. And especially considering the other HHS agencies component of the definition, there's a fair amount of resources that you can look for evidence-based programs. We have a question about Title III funds being used for participants under 60 years of age, and can the service units be accounted for? So Older Americans Act, of course, is for folks 60 and over, and so that remains the case. The network can, if there's infrastructure that the network has built with grants and with their work, and they're serving individuals under 60, that can take place, but that would not be reported in terms of units served. And that's basically the answer there.
Yeah, and this is Laura. If I could just add one more thing, Casey, is that okay?
Yeah, please.
If you're going to be serving individuals 60 and older and under in your programs, just make sure you have a good cost accounting system. If you have paid for the master trainers using 3D, that's fine. But then if you're holding a class, whatever the variable costs are, if half the class is, age 50, well, just be able to have a method for separating that.
Thank you. And related to costs, actually, we got a question from Juliet. Hi, Juliet. How does bulk ordering help reduce costs? Wouldn't the supplies then have to be shipped to far-reaching areas of the state?
I can handle that. It really does. So if you purchase 1,000 books from Bowl Publishing for your chronic disease self-management program, and then have multiple places to ship that to directly from Bowl, it would be astronomical. So what we do is we purchase that 1,000 books. We have them send it right to Atlanta to our Division of Aging Services, and then as our staff go out to do monitoring or mentoring at the various AAAs, we actually load vehicles and drive them to them, and we get to see people face-to-face and have another connection, but we also get to deliver the materials. So it is I keep saying that I'm never going to do it again, and then the cost just outweighs the pain in the, for doing it.
We really work with every section within the division, too, to make sure that these books get out, so we're not spending additional money. So if someone from our Medicaid waiver program is going to one region of the state, we load their car with books and send them off. If we're going to a meeting around a partnership with WIC Farmers Market, we load the car and send them off. So we really try to utilize every person who's leaving the state office to go anywhere in the state to get those books out.
And we have a very large state, geographically speaking, so as much trouble as it is, it really does save so much money, and you can get more books or more whatever you're looking for.
Great, thank you. We got a question. Someone couldn't find ADEP on the ACL.gov website. The name of that office just changed, so you may have a little trouble finding the link, but it should be linked to from the Title IIID page. And if you're having trouble, my contact info is on the screen now. You can just send me a note, and I can send you the link to ADEP. We also got a question about whether you can combine multiple highest tier evidence-based programs. That is not going to be an evidence-based program at that point, probably, unless it's been studied and it's kind of some sort of program with multiple components to it. But in general, no, you should not be combining multiple evidence-based programs.
Casey, this is Christy. I'm sorry to interrupt there. I just wanted to, that's not to say you can't implement multiple evidence-based programs through your 3D infrastructure. That's saying you can't pick and choose portions of multiple evidence-based programs to complete your own unique evidence-based program. It would no longer be considered an evidence-based program.
Right. Thank you. Okay, we're getting a bunch of great questions, and we're probably not going to have time to get to all these questions, so we will try and hold a list of who sent the questions and get back to you one-on-one. But definitely thank you for all these great questions. Okay, so this is a question from someone for, I guess, Georgia. Who holds the statewide license for the proprietary programs, the state or the AAA State Association?
The Division of Aging Services does.
Okay.
So the state.
Okay. I guess with only a few minutes left, I'd probably like to turn it back over to you guys. If you have any comments or main questions or comments you'd like to bring up to the group in our last few minutes.
I guess my only thing is be strategic and use your partners, partner, and see what they want to do, because if you have their buy-in, you can take it wherever you want to take it.
And my comment would be, if you've got an idea about a way to do something and you don't know if it's possible, just get in touch with your regional ACL folks. They have been so helpful to us along the way.
Absolutely. We cannot reiterate that enough. We rely on them a great deal, and we know the states and AAAs rely on them a great deal. So the regional ACL staff are really a crucial partner in this whole process. So again, apologies to those folks whose questions we didn't get to directly answer, but we will get back to you individually. There's some really great questions in here, and you have my contact info on the page there.
Yeah, and Casey, if some of the questions don't seem to be universal that we think a lot of you would be interested in, we do have a frequently asked questions part of the Title IIID webpage, and for some of these questions that are simply excellent, well, I mean, they're all excellent questions, but for ones that are universal, we'll make sure to add those to our FAQs.
Yes, absolutely. And just kind of in that theme, we're always looking to hear what interesting successes are going on in the states and AAAs. So if you have some great advice to answer any of the questions we may have heard, please don't hesitate to contact me. Don't hesitate to contact your regional representative at ACL, who would be great conduits, because they really need to know what is going on in the regions they work with so closely. So thank you all for being with us today, and thank you again so much to our presenters. You did a great job. And the slides and the audio of this will be available on the Title 3D website, which is right there within the next couple days. So thank you all, and have a great afternoon.